Um, I even go back a little farther in terms of following my patients from New York. But here at the Dattoli Cancer Center, we treated a patient. His name is Stewie Bitterman. He's here with us today, and he's going to tell his story as being one of the first patients to graduate from the Dattoli Cancer Center. So no further ado, Stewie.
Good evening, everybody. Good morning. Not good morning. I mean, I'm still awake. Well, in 2001, two things happened. We had the situation we had in New York, and we had Stewie Bitterman, who was diagnosed with prostate cancer. And that was in September of 2001, right after 9/11. And long story short, I was diagnosed with prostate cancer by my regular doctor, who said, "You have your PSA is up to 4.6. I don't know. I think you should go to a urologist," which I did. They did a biopsy on me, and the doctor was very, very kind. He called me and he said, "Mr. Bitterman, your biopsy came back. You've got prostate cancer. Well, let's go out and have a drink. What are we going to do now? What are you going to do now? You're going to come here. We're going to take it out. You shouldn't want to die." No. We went to his office here in Sarasota, and he said to me, "You're very lucky, Stu." He said, "I just had a cancellation, and I'm going to be able to do your operation in 2 weeks." And he put me down in his book, and my wife and I walked out, went down in the elevator. I said, "I'm delighted." He says, "No, you're not delighted. We're going to find out if there's any other choice." And sure enough, I got home that night, and a friend of mine that I played golf with called me up. He said, "We still, I understand you got prostate cancer." I said, "I do." He says, you got to speak to my guy." I said, "Who's your guy?" He says, "Michael Dattoli's on Fruitville Road." So why should I go to him? I already have a date to have the operation. He says, "Because that's," excuse the expression, "that's BS. You're not going to get any operation. You're going to get to Dattoli, who's got this new, just moved down here from New York. He was with a Sloan Kettering Hospital. He's got great credentials. I had my seating done by him. I'm feeling great, playing golf. Everything is fine. Go to him. Just go to him." Well, next day, my wife and I drove down here. We only live about 5 miles away from here. And walked into the office and the waiting room, and I asked the girl if I could have Dr. Dattoli call me. She says, "No." She says, "You give me your name, and I'll have Dr. Dattoli call you. He's going to have to ask you a million questions to see if you're qualified to have the seating," which I did. We came here, and Dr. Dattoli called me that night and decided to come here. And that was in October of 2001. And had seating. And all right, the first 2 or 3 weeks, I had a little burning in my urine. I called the office here. Dr. Dattoli prescribed a pill for me. The burning went away. PSA went away. And I've been coming back here every year for my follow-up. My PSA is 0.08. It's less than 1. And I feel great. Yeah, and my joke is, but I have this craziness. I never had this before him. Now for 21 years, I've been getting this damn thing. But I don't have any prostate cancer. Thank you. I'm here to help anybody here who wants help besides Dr. D. I mean, I couldn't do 1/3 of it, 1/8 of what he can do. But I'm here to answer questions from anybody that has anything that would like to talk to me about. I'm here. No charge.
Did you do hormone therapy?
No.
No. I'm sorry, I had to look at the doctor to get that answer.
He was on a modified version of hormones. He did not get the injectable, but he did the pill form of hormones for a brief period of time.
Anybody else? Oh, come on, someone has to have a guy. I get paid by the question. You know? He gives me $50 for every person that answers. So I live about 12 miles away from you. I'm not going to come here at 9 o'clock in the morning for $50.
What was your first reaction when you found out you had prostate cancer?
Well, to be honest with you, it wasn't the best day of my life.
Well, right. I'm in the same boat. We just found out.
I know, yeah, we discussed that.
Right. So I'm just wondering the avenues to which we can take. You got two opinions. How did you, by word of mouth, you got the second opinion to come here?
Right.
What other ways are there to get information about other modalities and doctors?
I guess the best answer for that is my wife, who is a very astute individual. She started doing research.
Yeah.
Yeah, she does it too?
Oh, sure.
All right, well, my wife does research.
Yeah.
And she started doing research on prostate cancer with the seeding.
Yeah.
And she actually had her ex-husband, who's a doctor in New York, go to Sloan Kettering to get information about prostate cancer. And she said, Stu, this Dr. Dattoli has got some background. And he's right here in Sarasota. And by the way, if anybody remembers Mayor Giuliani,
I think so, yes.
Giuliani came down here, didn't he?
Yeah, but he ended up having surgery though.
Yeah. He came down here, and from what I understand, because I have a friend who recently passed away, who came down to my friend Dirk.
Dirk Bung.
And Dirk was a lobbyist in Washington, D.C. And he came down here for prostate cancer. I never knew him, but Dr. Dattoli asked, my friend Dirk asked Dr. Dattoli for a reference, and Dr. Dattoli gave it to me, and this gentleman called me out of the clear blue sky, and he said, I'm thinking of going to Dr. Dattoli. Tell me about him. And I told him he's the greatest guy in the world, saved my life. Anyway, Dirk was able to get a hold of Giuliani to come down here. But that was when Giuliani was still in the throes of politics in New York. And he didn't want to come down here for 6-7 weeks and get treated. So he went to, I think he went to Sloan Kettering.
Actually, Mount Sinai.
Mount Sinai. Mount Sinai, Sloan Kettering, same thing. And still around. But there's a lot of, from what I understand, there's a lot of disadvantages to the operation. A cousin of mine from New Jersey had prostate cancer, called me up. He said, Stu, he said, you're a guy down in Sarasota. You think I should go to him? I said, if you want to live, you should go to him. Yeah, I think it's a pretty good idea. Well, his doctor up in New Jersey said, you don't want that seeding. It's something that'll it'll never stay around. You know, it's hot now, but who knows what's going to happen 2 years from now or 3 years from now. No, I think you're better off going for the operation. And my cousin went for the operation. Was never the same man. Never. He had all sorts of issues, and he's still alive, but he's got problems. But
Did you know what stage you were in? How often or how soon did you find out the stage? Because I don't even know. I'm just having a test. What about the stage? Are there different stages require different types of surgery? Or, we're here to ask about that.
Sure.
I want to get direction of where I need to go and what I need to do, what we need to do. So
Yeah, I'll be happy to answer your questions in some
Don't
detail.
take over the podium. I'm serious.
Anyhow,
You were here before. Go ahead.
Stewie got to sign that wall 15 years ago, and that's,
No, 21 years.
5 years in.
Oh, 5
Yeah.
years in. Yeah, that's right.
The wall of
Yeah,
fame.
you're right.
Anyhow. Okay,
yeah,
well, we can,
No, the gentleman has a question. Maybe you can answer.
well, yeah,
yeah, he's on it, I guess.
so there's different treatments per stage. The prostate cancer is staged by either 1 to 4. 4 means it's cancer's out of the box, it's gone somewhere else. Okay, and then
Okay.
along the way, there's stage 1, stage 2, stage 3. You rarely see a stage 1. Okay, but depending if it's stage 1 or 2, those patients could either have surgical removal called radical prostatectomy, or they can have radiation of some variety. There's protons, neutrons, photons, electrons. There's all different types of radiation treatments. There's other options as well, which have been used with some success, and those we call ablation therapies, where you freeze it or you heat it. I'm not a big fan of those. I did hundreds of those in New York. They only lead to needing more and more and more of those until the cancer is widely spread. And so I'm not a big fan of those. And they have their own sundry of complications once you've done more than one. And virtually everyone needs more than one of the focal ablations.
I just like to say one more little anecdote. I used to live on Longboat Key, which is one of the islands here.
Yes.
When I first came down to Sarasota 30 some odd years ago. And one of my golf partners was a member of the Sarasota Memorial Hospital board. Nice guy. And we're out playing golf one day, and he said to me, "Stu, I understand you got prostate cancer." I said, "Yeah." He says, "What are you going to be doing?" Well, I did a lot of research, and Margie, my wife, did a lot of research, and I'm going to be going with Dr. Dattoli. He said, "No kidding." I said, "Why?" He said, "Well, I've been on the board at a hospital now for 7, 8 years, whatever it was. And I only wish that the hospital had the machinery in our hospital that Dattoli has in his office. We don't have it. And to get the radiation and to get the seating is something that we don't do here at the hospital, but I wish we did."
Yeah, okay.
So that was a pretty good.
So you didn't have your doctor get in touch with him. You did it
No.
yourself.
Oh yeah.
You did it yourself.
No, I didn't want my doctor to get the commission.
Yeah. Yeah, well, that's all well and good, but I'm not sure that I understand why you didn't do that. You just had your first visit with him and figured this is the way to go
Well, you know what?
versus other ways.
Yeah, well, I sat down with my wife. Honest to God, I sat down with a bottle of red wine. I said, "What do I do? What do I do? I have a choice. I can either get the operation,
Right.
to get it cut out,
Right.
with the idea of not getting the whole prostate removed,
Oh.
and some of the cancer goes into my system, and once it gets into my system, I'm toast."
But that's not necessarily what happens. Sometimes
No,
they
it's-
get it all.
No, it's not necessarily, but it's something, I thought that the seeding was a lot easier and a lot less invasive.
Well, and I read that you can have the surgery and then have the seeding to kill any remaining cancer that's in there.
I'm not familiar with that.
actually, that would be a very rare situation to do seeding after that, but many patients who have surgery, I'm going to take the podium,
Oh,
okay?
sure. I think somebody had it.
Oh,
Hey, it's $50 a person.
no, I
Got another.
I have to wash this car.
Get your checkbook out.
Yeah, someone had a, yes, sir.
I was just going to ask, did you just have the seating? Did you-
Yes.
Yeah.
Well, had the seeding and the radiation.
Okay.
And after I think it was 23 radiation treatments. After I had the seeding, I had another 5, I think.
Maybe 10, but yeah.
Maybe 10. This is it? We can walk our way over $100?
Yeah.
Okay,
Gil?
you have anything else, sir?
No, sir.
He's gonna,
I think that
Thank you.
most men think that if they have an aggressive prostate cancer, they're typically told by the urologist that, okay, it's aggressive, we better take it out. And in reality, that's probably the worst case scenario, because when it is aggressive, it's likely to have microscopic elements beyond the prostate that surgery cannot get removed. Surgery is very limited in terms of what you can remove. You know, it's done with a Da Vinci robotic procedure. You can't remove prostate cancer like you do other cancers. Other cancers, for example, if this was a cancer in your body, we often think that that may be it, but it's got tentacles like that. And because of that principle, and you can't see these, but your oncologic surgeons know they exist. So when you take the cancer out, you try to take a large swath around it, but you just can't do that with prostate removal because the prostate is bounded by so many critical structures: your bladder, your rectum, neurovascular bundles and veins, the urogenital diaphragm, anal rectum, proximal crew. There's just too much down there. I used to do it. And in the process also, you lose a lot of blood. And if you just use Dr. Google and ask how much blood is typically lost during an operation to the prostate, you'll find it's about average somewhere between, ranges 600 to 1600, and medians probably around 800 or 900. That's off the chart from the standpoint of other cancer operations. And you just can't make the prostate surgery bloodless. But in the process, and again, if you use Dr. Google and ask the question, does prostate cancer removal disseminate prostate cancer? There's a large body of data suggesting that. But anyhow, we talked about the earlier stages, and then of course stage 3 is a little more locally advanced. But what I was actually getting at is that the higher the Gleason score, the more aggressive the cancer is, the higher the probability that these are out there, and that when you remove the prostate surgically, you're not going to get them all, and or you leave those cancer cells behind or left to disperse. Also, having been involved with prostate cancer for so long, I've come to realize there's never been a prostate entirely removed at the time of prostate surgery. And you know, here we measure them, and I have been measuring prostate cancer or prostate glands in the postoperative setting after a radical prostatectomy. There's always tissue left behind. And, you know, which is the same tissue that you had your prostate cancer arise from in the first place. So, and that's the reason why, if you look at the surgical data, if you get out of the woods after the 5-year period, you're never out of the woods after radical prostatectomy, because the same tissue has been subject to the same environmental cues, genetic cues, and it's going to become malignant over time. Anyhow, when we get into the more advanced prostate cancers, which is typically stage 4, and you know, it's interesting because the last couple of times I spoke, I put out a paper that I published in 2024 in the Journal of Clinical Oncology, having to do with, if the cancer recurs after radiation, what do you do? Okay, and I published on that. We have the largest series in the world, and they're not my patients. They're patients treated with radiation elsewhere, but we were able to rescue most of them with high, good rate of return in terms of cure and lower side effects. But the fact is, when you do get into the stage 4, it becomes more challenging. And I'm writing a paper, and I put the paper out there. It's like a first draft, but it's a paper on my prostate cancer has spread. What do I do now? Because a lot of times the people who look at your case, and if it's the urologist, well, he can only do something if he can take your prostate out. Okay, he can't do radiation. So typically he'll say, you need chemotherapy or hormones, and he sends you off for just that treatment alone. And what happened was, going back actually in time, there was a really interesting paper, and it had to do with patients with prostate cancer whose cancers had spread, and removing the prostate site or irradiating the prostate site. It was primarily became a radiation-based paper over time. And what it identified was that by treating the prostate with radiation, it actually had an effect on cancer which was outside the prostate, which had spread. And that was very interesting. It became named the abscopal effect of radiation. And that body of data is what jettisoned a lot more research into ways of countering prostate cancer when it has actually spread. And today, what I do, and I try to base everything I do on hardcore data. What we try to do is, yes, we'll treat the prostate and the relevant tissues around it, which includes lymph nodes, which are little scavengers that we have throughout our pelvis areas that remove things that are not supposed to be there. We treat those as well because they seem to be the same as the prostate cancer, which may have influence in other sites of the body, kind of like the conductor of the orchestra. But we also know that if there's sanctuaries outside the prostate, whether it is lymph nodes, whether it's bone, whether it's liver or lung, and if they're large, well, it's maybe too large for those cancers, microscopic cancers, metastatic microscopic cancers to resolve and go away. So, because they're not microscopic, they're macroscopic. So what we do is we also treat those with focused radiation. And here we use a very focused type of radiation called DART. An acronym is called DART. It's Dynamic Adaptive Radiation Therapy, meaning we can actually move with your body's motion in real time. And that's very unique. And probably, many of the reasons why men come here is because of that uniqueness of the type of radiation, which we never stop upgrading. When I treated Stewie, we had at that time the greatest, latest radiation. It was called IMRT and IGRT, which was the brainchild of Memorial Sloan Kettering Cancer Center in New York. And I brought the team here with that therapy, and I combined it with the seed implant and noticed these great results. And over the years, we've never stopped refining and retooling the external beam radiation. And we've been helped by some very generous donors, wealthy donors throughout the years where, sometimes if you donate money to a large medical center, university, you never know where it's going. But when we have our donors, it goes directly to, into our technologies here. And we always have the very highest and latest technologies. So that's kind of like, how we do things. Hormones become really important when it's stage 4 disease, when it has gone to lymph nodes or bones. And hormones have their own effect in terms of squelching the cancer. But it's very interesting that when you give the two treatments together simultaneously, radiation and hormones, you get a really big effect. And I often tell patients it's 1 + 1 equaling 5 or 6. It's a bigger number. And we call the hormones in that case radiation sensitizers because they just make the radiation work better. And we didn't know why that was for a long time, but now we realize it's because each of those hormones spike the immune system upwards. It makes it stronger. Contrast, surgery drops your immune system. Chemotherapy drops your immune system. Hormones upregulate your immune system, as does radiation. And that was another paper that I often give. I don't know if it's out there. I talk about the title of the article is Good Radiation, and it talks about how those who have received radiation in the past live longer, have less cancers, less diseases, because your immune system is spiked up for life. So that's a very interesting side note. But with it, more advanced cancers, we commonly give hormones, radiation, with or without seed implants, and we're more and more using agents like immunotherapies and second-line hormones. And 6-7 years ago, we didn't have them. Now we have 4 new drugs, which are not chemotherapy, and they're second-line agents, which actually don't even drop the testosterone, which is very interesting. And we use those simultaneously now to get even a bigger spike from the radiation. And we also use some other interesting monoclonal antibodies. Want to thank people from Provenge. They're providing your breakfast, and we use their product, which is very interesting, and I often refer to it as a designer immunotherapy. And you basically have your blood harvested and then sent out to a specialized laboratory, which makes antibodies to come back, to be infused back into your body. It's very interesting. It's called Provenge. It's made by the company called Dendrion. But anyhow, I'll open the floor for questions. Yes, sir.
I have a question about the PSA. You successfully treated and cured my father. His PSA was 22, I believe, 30 years ago. And it was also, the cancer was outside the prostate, and you also cured my younger brother. my question is, what's the highest PSA that you treated and were able to cure?
Yeah, the number is 1,200, and it's a gentleman from Tokyo, and we treated him very aggressively. Actually, it's going on his 20th year now, and his PSA is undetectable. He came here, identified where, just as I told you, where the sites where it had metastasized or spread to, treated those aggressively, and he did well for about 10 years. His PSA began to climb. At the time we were doing nanoparticle imaging, and which is really advanced type of imaging. I've published on it. You'll see some posters in the back specifically on these nanoparticles, and I picked up additional disease, and that was just over, it's actually 12 years ago now. I treated those, and he's been cancer-free forever. So, to this day, I just saw him in follow-up a couple weeks ago, and he's enjoyed a really good life.
So basically you don't do surgery, you only do the radiation.
Yes, I don't do surgery. I used to do surgery. I only do varying types of radiation.
Okay, and when you do the radiation, like your example there, it gets those little tentacles going out.
It does. It does. And there's also structures I've mentioned called lymph nodes, and they're throughout our pelvis, and they sit like that, and these guys end up going to them. And in many cases, we think it might be a good thing, because if the cancers go to these and they continue to go up like a ladder, they start from lower, and lymph nodes go up, 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 right up to, right up to here, behind our ear. And we think, though, that if it's caught in lymph nodes, it may be trapped for a while before it actually does disseminate into the circulation. So, but lymph nodes we do treat. I have a lot of experience treating lymph nodes because of the fact that we were doing these advanced imaging called nanoparticle. We called it Combidex and USPIO imaging. There's also more recently the advent of PSMA PET scans, which we've been doing, and I think we were one of the first. We were the first. We were working with the University of Michigan, Ann Arbor, with PSMA PET scans when they began it in latter 2014 or early 2015, and we did have the advantage of using both nanoparticles and PSMA. Nanoparticles were better. We're trying to get them back, but they're not. Yes.
Okay, now I just lost my train of thought.
Well, I'll take another question.
What are the side effects
Side effects
of the radiation?
Yeah, so typically radiation can produce inflammation, and since we're treating the region of the prostate, which is nestled between your rectum and your bladder and the urethra going down the middle of it, you can get increased urinary symptoms. It doesn't have to be, and what I tell people is you may not have it, at all, but if you do, it's probably going to be mild unless there's some anatomical variant of your prostate. But it's certainly less than when we use, for example, even IMRT, as Stewie was treated, 21 years ago. It's different now. It's that much more precise. We can target prostate and the lymph nodes with really minor side effects.
No bowel issues?
Typically not. We don't see a lot of bowel.
So symptoms are what? What would you say?
Could be frequency, urgency, weakening of the stream.
Right.
Okay. In the back?
Yes, so I was recently diagnosed in August via biopsy. And so all indications are they caught it very early, which just showed up in one of the 12 core samples. So I'm currently, the urologist has me on active surveillance, which makes me a little bit leery. I lost my father at age 54, prostate cancer stage 4, so very early, having monitoring for a long time. So it's a two-part question. One is, what is your point of view on the whole active surveillance once it's been diagnosed? And so I'm at Gleason 6 at this point.
Sure.
The MRI doesn't indicate any kind of tumor. The DRE isn't indicated any kind of tumor. So one is your opinion on kind of this active surveillance once you have diagnosis. And then the second piece is your particular procedure, if it's not tumor specific, or just showing up on one of the core samples, does it apply to that kind of situation as well? Does that make sense?
Yeah, so the gentleman is asking about something we call active surveillance. which I reserve for, and I follow hundreds of patients with active surveillance who've had their prostate cancers, but it's very, very minimal and it's a low grade. I'm concerned about men being tracked who have slightly higher grade tumors, especially Gleason 7s. And so my perspective, from my take and the way I follow patients with active surveillance, you should have 2 or less areas that are malignant with a lower Gleason score, perhaps Gleason 6, and it should not have a high volume because volume is another issue. And the higher the volume, the faster or the higher the probability that it's going to mutate. Prostate cancers don't go away. Just that's a fact. And I've been doing active surveillance and what used to be called watchful waiting for a very long time. They don't go away, so you really you are kicking the can down. Some of the problems that I'm seeing today, and I've written on this. It's called active surveillance: the dark side. And I just point out some of the weaknesses of the theory. Is that as time goes on, and what you do is I got prostate cancer, I start changing my diet. I'm doing fruits and vegetables and nuts. I'm not having red meat and pork. I'm not fueling it. I'm doing all the right things. I'm taking lycopene. It has anti-prostate cancer effects. And guess what? My PSA is going down. That gets my attention more than if it's going up slightly, because what happens with prostate cancer is when it's low-grade prostate cancer, the cells resemble the normal prostate. And so the cells are kind of similar. They make more PSA because it is cancer. It's growing a little faster. But when it starts becoming more aggressive, it starts to lose its face to the prostate cell. And it's not having to make PSA at all. And so that happens as we go onward. And a lot of times, patients, they think they're in a real safe zone because their PSA is going down and I'm doing all the right things. And little do they know that they're actually now harboring, some Gleason 8, 9, 10 tumor that's very aggressive. So I think there's a role for active surveillance. The real reason is that there are side effects, and certainly associated with surgery, where you have incontinence and leakage and sexual dysfunction, because the prostate is a sexual organ. That's what it is. It's the G spot in men, and so certainly if you're spared from surgery, well, you are spared from those side effects for a while, and then of course the radiation. Generally speaking, and there are some side effects like I mentioned, frequency, urgency, but if you get it done right, it's not so bad. But you need to have it followed closely. MRIs are very good. Here we use a special instrument. It's called a 3-dimensional color flow power Doppler ultrasound, and it's very, very accurate in terms of looking at the cancer in the prostate, seeing exactly where it is. And then when you come back for a follow-up, be it 6 months or a year, we look exactly at that area to see has it progressed, or are there other areas of the prostate that are becoming malignant. There's something that happens with the prostate, we call it a field effect. And what that means is that all of the tissues of the prostate gland have been subject to whatever gave you the prostate cancer to begin with. If it was maybe a genetic predisposition because you have relatives who've had prostate cancer, or maybe female relatives who have breast or ovarian cancers, which again puts you at a higher risk for developing prostate cancer. But the whole gland, so that the prostate gland is like this. Well, if you got a cancer here, you're also going to, over time, develop a cancer here, 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 here. It's called the field effect or field cancerization. There are 2 areas of the body that you should take note in. One is, and they're very similar, it's very interesting, and that is patients having breast cancer or have the same such thing called field cancerization. And it's very interesting because prostate cancer is fed by the male hormone testosterone. The breast is by estrogen. Prostate cancer likes to go to lymph nodes in the pelvic area. In women, you often talk about the lymph nodes under the armpit. And they both can be controlled for a very long period of time with differing methods, including hormones for each. But anyhow, you have to still be careful, because I've noticed that a lot of men are being followed with active surveillance who really shouldn't be. And they're not aware because they think, the urologists are the experts. But, it's kind of like buyer beware. But again, I do follow patients, and I'll be the first one to tell them it's something, is advancing. One of the problems with prostate cancer has to do with where cancers of the prostate begin. So that if, again, this is the prostate gland, here's the urethra, goes right down the center. Most cancers of the prostate don't begin here. Okay, they begin right on the edge. That's a problem because that's where they begin. It's called the peripheral zone. And, 99% prostate cancers begin in the so-called peripheral zone. And the reason that's so important is they do have access to the outskirts. The prostate does not have a capsule. And again, you all could just do Dr. Google and ask, does the prostate have a capsule? It definitely does not. And that's the reason why, as I was mentioning earlier, cancers begin in the periphery. Well, they're already on the edge. And so if the cancers do what I was showing you earlier, they invade the tissues microscopically. Well, there's nothing holding them from this side either. So they go like that. And that's one of the big bugaboos with prostate cancer, does not have a capsule. And so from a surgical perspective, you try to remove like this and you can't see those. So you come around like that. And if you had a before and after picture, the prostate's gone, but those tentacles are still there. And that's, one of the things that you run into with, the so-called radical prostatectomy. Is that clear, sir?
Yes.
Okay. Are there any other questions?
But why isn't brachy advocated more often by doctors? Because I had 3 people in San Francisco advocate I had my prostate cut out. Went to 3 doctors. We're surgeons. We're going to cut it out. So I came here. Very glad I did.
Yeah. So the gentleman's asking why aren't more advocating brachytherapy, and it is unfortunate because if you look at the data, the data is really clear. There's a current study that's ongoing. It's called the Ascend RT trial. It's a double-blind, placebo-controlled trial in North America. So it's Canada, North America, and the data keeps accruing and it keeps showing the advantage of brachytherapy. But and because of that, more and more places are doing it. So I know a center just opened up in Jacksonville, and that's what they're doing, and that's a good thing. I know University of Pittsburgh is doing a lot of it. Harvard just started doing it again. The unfortunate part of it is that they're not teaching it in residency programs in radiation oncology. So for a long time, I was teaching most men in the United States along with a doctor in Seattle, Washington, and we were both kind of training after the residency programs. Again, I had a lot to do with developing prostate brachytherapy, in New York City. And at first, there was so much enthusiasm, and residency programs were training their doctors how to do it. And then just kind of fell by the wayside. And I think one of the reasons is radiation oncologists, they're not surgeons. Okay, now I've spent time in my life doing surgery, so I have no problem doing brachytherapy. But radiation oncologists are like radiologists, and they're not usually touching anything. They're just accustomed to looking at scans on a film board, And so as soon as they didn't have to do it, it was like, okay, I don't have, I can wipe my hands of that. I don't have to do it, and that's unfortunate, So, but there are radiation oncologists who are more savvy, who have no problem, dealing with tissues. But it is a minimally invasive procedure too. So there's no cutting, no incisions, there's minimal blood loss. So I think it's a wonderful procedure.
I have one other question. How much does the proton therapy machine that you have, that wonderful engineering device, how much does that cost?
Those are typically, ballparks, in the tens of millions of dollars range. Very expensive. Yeah, but it's mostly all the other operating system around it that gets really costly. Yes, sir, in the back.
I was just looking at what types of external beam radiation therapy do you do here? You've got proton, you've got IMRT and SBRT. Do all 3 here?
So within the realm of radiation delivery systems, there's many types. There's protons, neutrons, photons, and electrons. Okay, and they all have kind of the same endpoint. They're trying to get a dose to a target somewhere. Here we use something called dynamic adaptive radiation therapy, and you'll often read about it. It's called DART. It's very unique to this cancer center, and a lot of it has to do with some really intelligent people And when I was in New York at Sloan Kettering, I aligned with a couple of really brilliant physicists. Both were Nobel laureate nominees. And we currently still have, as a consultant, one of those on staff. But a long time ago, they were actually the ones who came up with something called IMRT. And IMRT is very precise radiation. It's computerized radiation. It was a revolution in the field when Sloan Kettering developed it. This center was the first freestanding center in the world to do it. But it wasn't long before we started to realize that even with IMRT, or IGRT is another word for it, we were still seeing a little more bladder and rectal irritation and agitation. And that got our attention. And it wasn't until 2016 when we actually put forth a culmination of imaging technologies which track where your body is while you're being treated. So there's no room for error. And that's what DART is. It's dynamic adaptive radiation therapy. We happen to have the highest energy linear accelerators in the world. And so we utilize high energy photons to achieve that.
And how do you define the difference between localized prostate cancer versus, I guess, not localized, and the application of radiation to those
Sure.
situation?
So the gentleman's asking how do we identify localized, how we think of localized, how we find it, or is it more advanced? And I think that comes out of the workup. So again, how high is your PSA? If it's a high PSA, higher probability that it's beyond the prostate. If it's a higher Gleason grade, 7 through 10, higher probability it's beyond the prostate. If there's perineural invasion, meaning you see prostate cancer on a nerve, as I told you, cancers of the prostate are just itching to get out of the gland. And if you find it on a nerve, there's a neural network that goes like that, inside, outside. If you find cancer on the nerve, then it even gets a freer ride outside the prostate. That's microscopic, though. You don't necessarily see that, but you kind of think that, high PSA, high Gleason grade, it is probably outside the prostate microscopically. But I do want to say another thing, and that is those Gleason 8 through 10s, the more aggressive prostate cancers. I've treated men with PSAs of 0.2, with really high volume disease. So you need to also be very wary of that, if it's a higher Gleason grade. And so we do, pay attention. But it's still interesting because if you get that 0.2 to become, undetectable, that seems to be valuable as well in terms of getting rid of the prostate cancer entirely. But it's a culmination of technology. So you got the PSA, you have the biopsy, whether it's perineural invasion, how high was the volume. When I do biopsies, we send them to the pathologist and he gives us a read. The core that I sent him, did it involve 10% or did it involve 90%? It's 90% higher volume. And again, going back to the active surveillance, if it's 90%, there's just more cells to mutate, and they always mutate. Prostate cancer doesn't mutate from a Gleason 7 to a 6 to a 5. It always goes upwards, 7, 8, 9. All cancers do. As they mutate, they dedifferentiate, they become less and less like their parent cells and they become more aggressive. Today, there's staging studies. We do light speed, fine section Hill CT scans here, but we also recommend select patients, not everyone, gets PSMA PET scans, and we have places around the community that are now doing that, and they do it really well to determine whether the cancer is beyond the prostate. But what I've identified with PSMA PET scans is that if there's something that's showing on the scans, it's a lot of disease. It's at least 10 to the 6. It's a billion cells or more. It's got to be macroscopic. And so, just so you're aware of that. Okay. Yes, sir.
You used a quote that it said that urologists are experts, which you kind of did tongue in cheek. And I get that. However, what am I, brand new at this, what am I supposed to take from my urologist says X or Y or Z? Since I don't believe that he's the expert, I'm finding that to be true. What are my options when he said, Gary, I think you ought to go and have it removed and see my partner who's a surgeon?
Yeah.
So he's the expert. What am I to do? Come to you?
It's the right place.
I'm at the right place. Yeah, I'm beginning to feel as if and that's why we're here to find out
Yeah.
what are my options.
Yeah, well, you know, what he's asking is, you know, how do you cut to the chase when, you know, you have differing doctors pretty much recommending what they do, and I'm no exception.
Right.
Okay, really. But I have my opinions based on a lot of data. And what had happened was a very long time ago, when I was in New York and doing some surgeries of the prostate, the way it would work in New York at Sloan Kettering is that we would just see do so many surgeries one day, and the next day you're kind of cast into the clinic where you see guys who had their prostates removed 2 weeks, 2 months, 2 years ago. And it became very clear to me, most men have incontinence or leakage, you know, which is a problem. And then as I was saying, the prostate's a sexual organ. It's the G spot in men, okay, and has everything to do with most of creating the ejaculate. It has a lot to do with harboring the nerves that go to the penis to create an erection. It's the organ that upon orgasm mechanically contracts to pull the ejaculate out. So it's a really sexual organ. So you just think about that. If you have your prostate removed, you know, it's going to be difficult. And I have men who've had their prostates removed. They have complete erectile dysfunction. They go and get a penile implant. You know, and yeah, that works, but now they can't get they can't get an ejaculate, they can't get an orgasm, which most men will say, well, I would take the orgasm over the erection. So, you know, yeah, so yeah, exactly. So anyhow, these are issues, but it's really hard to figure out. The best I can suggest to you is do a lot of research. And you know, you have your wife there.
We feel like that's all we're doing and it's all conflicting.
I mean, you know,
you're making the good points. You're making really good points that I've been reading too. She does a lot of it, but I have too because it's me.
Sure.
But
there are websites.
Are you the only one that does it, or you have other doctors on your staff? Or
yeah, Dr. Sony's my partner, and he does them as well. I have a real savvy nursing staff too, but they don't do the procedures, you know.
So there are two of you that actually do the procedures.
That's right.
Okay.
So let's say that we decided to do this.
Yeah.
We've already had the biopsy and come up with the Gleason score, and he's had a bone scan, and he's going to be having a CT with contrast and blood work.
Okay.
Do we have to redo all those with you?
Typically not, but I would want to do, upon consultation, a 3D color Doppler ultrasound. That's a very unique instrument, a very rare instrument. No one else has it. I mean, you know, we know who has it. UCLA has it.
There's only 2 or 3 in the country.
Yeah, there are. Yeah, and we actually have
what insurances though?
that. I don't know. That you have to take up with the billing
Yeah,
office.
you don't get into that. No.
No, it is confusing. There's websites, you know, to tell you, you know, more information. You know, I try to go over things in detail even before you come here to determine if you want to come here. I usually call you, typically at night or on the weekends or something like that. You know, or sometimes during lunch if I can find the time. But I do call a lot of men, whether they come here or not. You know,
to do an interview type.
That's right. That's right. Just to determine how well of a candidate, you know.
Well, it's good. I mean, it protects you and it protects the doctor.
Yeah.
I mean, you know.
Have I done enough for you to evaluate based upon what you've briefly heard from us now? And
it sounds like you've had a biopsy. It sounds like you're getting, you know, you're getting some CT scans as part of the workup. You know, I don't know. That probably is it. You know, we would do our own scans here with, as I say, 3D Doppler ultrasound is really revealing of things. It tells us a lot.
Okay. Well, call me.
I will back up to what he just said about his ultrasound. Back up a little bit. Tuesday was my first official visit here. Me and my wife here was totally amazed. After dealing short of 3 years with this prostate cancer, I never had a doctor sit down and explain, point things out on his ultrasound like Dr. Dattoli did.
Thank you.
I have another story. When Dr. Dattoli called me for the first time, it was about 7 o'clock at night. I was just having dinner right here with my wife at home. And my wife said, "Hey, Stu, get on the phone. It's Dr. Dattoli." I said, 7:30 at night? He had me on the phone for at least 45 minutes. And he was on his way home. I found out later. And gave me all the information I wanted to know. I mean, how many doctors would do that?
Well, you're giving a first good impression to me.
Oh, me or him?
Not you. Jesus, you're like,
What do you mean not me?
please, give me a break.
Yeah,
Turn
you're
around.
okay, you're okay.
Turn around. You're good.
Now, what was his name? Bonnie Dangerfield?
Yeah,
That was
yeah,
so-
I'll take you $50. But first impressions are important and this is a serious condition, right?
Oh, it
This
is.
is nothing to play around with. So I like to have jokes and I like to enjoy myself. But I also want to go to somebody that knows what the hell they're doing and is going to give me good information and take care of me. And it's sounding very positive here. You're like a car salesman. Sounds like to me you've got the best deal in town, so to speak.
Do you need a referral?
No,
No,
no.
no, that doesn't surprise me. No. All right.
Yes, sir.
It might be helpful. I saw 3 urologists. The first one was an arrogant ass, so I cut him off.
Coincidence.
Sound like my ex-wife.
Mine too.
What's your name?
What was
You
the-
and I,
Anyway, the second one recommended hormonal therapy for 1.5 to 2 years with horrible side effects. So, well, that was the next guy to go. The third one was a surgeon. All they wanted to do was operate. That's it. So I just happened to bump into somebody that had been treated here, and this is where you want to be. This is without a doubt, it's a no-brainer.
I think I can relate to your story. Yeah, I'm serious.
Unbelievable.
Really?
So if we decided to go to radiation.
Yeah.
Then, what,
I have-
you do seeds
I
and
have like 6
external?
more radiation treatments.
Yeah, everyone's different. Some people just get the dart, other people get the brachytherapy. Sometimes it's an option.
Okay, brachytherapy is the seeds.
Seed implant, yes.
Okay.
Mhm.
And DART is the external?
Yes.
Okay.
you know, if you're out and about looking to buy a new car, the first thing, my family was in the automobile business all my life. And you go to the Jaguar dealer, see this beautiful Jaguar, it's $112,000. You're ready to say to yourself, you know, I think I'll buy this car. They said, and the salesman will say to you, just sign the paper right over here. Now, but wait a second, hold it. Before I sign the paper, I want to go down a block. I want to take a look at that Porsche. That Porsche is good. Well, it's the same thing here. You know, you've been diagnosed with prostate cancer, and there's 5 or 6 different ways that you can go. You have to make it up your mind.
No, I get it. I get it. I get it. I was in sales. I give options and
Yeah,
this is very similar to
it's
that.
very similar.
Very similar, but we're talking about my body. So,
Oh, yeah.
so, all right.
Gentlemen.
Something I think that you need to do is come downstairs and to the waiting room and sit and listen to the different stories.
I am so glad you said
It
that.
is amazing.
I'm so glad you
Yes.
said
What are you guys doing down back here? Everybody's cheering this place on. I mean, it must be,
Has everybody already been here?
Yeah,
Why are
you
you here
guys-
today then?
See what other people have to say. I'm serious. This is my second visit here.
yeah.
It's just awesome to sit here with this group and see what everybody's opinion is.
And it's very similar to what you heard all
But you're
along,
already
right?
doing
The same
treatment.
question?
Are you
Yeah.
done with treatment?
Starting next week.
Oh, okay.
Oh, you're starting next week. Oh, okay. So you know your stage and everything, which I don't know that.
We have a Gleason score, but that's all.
Yeah. He's good.
I just,
Go ahead.
yeah, I want to get there because I know we're
Yeah,
getting
I'm
close to
sorry.
the hour.
I'm
The
sorry.
gentleman here in a striped,
I'm from Salem, Massachusetts, and I don't know if anybody's heard of Mass General
Yeah.
Hospital. It is a very, very large, world-renowned institution, and they do cancer treatment, prostate and all that. And I live right next door to Danvers, which is one of their places. And I went there because my PSA went from 4 to 24 in 1 year. And I had no idea what the deal was. You know, my doctor, my personal doctor, sent me to a urologist, and he just did the inspection and gave the samples and sent them in, and there was cancer in it. So then they had me meet with a Mass General people. I met with three, a surgeon, and whatever. They weren't pushing surgery, but my wife, and I'm just giving this story because I think it would be good for you and for us all. This the reason I'm just almost done. I have 6 more treatments, I think it is. And then I go to seed, 4 more treatments. Then I go to seeding. But the reason I happened to come here is my wife was going to her Bible study with her lady friends at our church, not our church, a church we go to. And she asked for prayer. One of the ladies there said, "Oh, what's going on?" A friend of her friend's husband had prostate cancer and came here 10 years ago. She said, "You should talk with him." So I called him. I spent an hour plus with he and his wife on the phone, and they told me we were working with Mass General, but they were like pushing us down the road. Now, I didn't get that feeling they were going to push me down the road. I was very comfortable. Mass General's a well-known place. But the positive information I got from them about how he was treated 10 years ago and he's free, and he comes back, I guess, once a year, really gave me a positive feeling, you know, God's put me in the right direction. Well, 2 days later, I talked to Dr. Dattoli personally on the phone at no charge for 1 hour. And he wasn't like, "Look, you need to come down here, blah, blah, I'm selling my stuff, no. What you've got can be taken care of, basically, is what I got from him by my treatment. And the dart was what really intrigued me, because Mass General said, if we do radiation, you will have burn marks.
Yeah.
I have 0 burn marks, and I'm coming up on 40 treatments. I don't have a lot of problems from the radiation. I don't think it was more from some of the medications. Right now, though, I do have the urinary Russian. Yeah, yesterday was pretty bad for me as far as the urgency.
Yeah.
And I had to pull over on the highway and go around the side of the car.
It'll subside.
Yeah.
It subsides.
Yes. So
How long does it usually take to subside?
Everybody's different, you know, it could be days to weeks, sometimes it's a few months. So it just depends.
We mentioned medication. Does it, do you have to have
We do.
medication when you do?
We remedy things, you know, symptoms. I want to just get back here, gentlemen. Yes, sir.
When you irradiate, are you irradiating the whole prostate or just specific sections of the prostate?
So he's asking if we irradiate the whole prostate or specific section. So what we do here, and again, it's unique, is that we do treat the entire prostate, but the areas that we identify to be malignant get the higher dose levels, both with the DART as well as dose escalation with the brachytherapy. So we do selectively treat different areas to different doses in the gland and outside the gland. Okay.
I do have one further.
Yes.
I have a question.
Okay. Yes.
Once we're done with the seeding, is there a problem? I know you need a little bit of time after you have it, so you have to check us out, check me out. Is there a problem getting onto a plane and taking a flight as far as?
It's not, but he's asking about seating and, you know, travel. Yeah, if it's done really quickly, if you get back on the plane, they will, you know, since 9/11, they've turned up their Geiger counters to pick up almost anything, you know, and they do. So with radiation, the way it is when you have the date of the seeding, that's when you might have some dose that can be picked up with a really, you know, strong detector. But as the days go by, it goes down. And depending on the isotope makes that difference. The cesium 131 has a 10-day half-life, and palladium is 17 days. So it just depends on the isotope. But they're very familiar with this at airports now, certainly at these airports in Florida, because you know what we do here, and they're all familiar with it. But you know, if you come in other international airports, they probably are familiar with it too. Or you just tell them, we give you a letter telling you had this and all about it, and they know that.
But no problem physically.
No problem
Oh.
physically. Not at
No
all.
information
From
from these, you know.
well, you could have some frequency, you know, urgency. You can.
The seeds, are they the ones that are planted and then you wait and then they remove them, or are they planted and they eventually disintegrate?
So she's asking if the seeds are permanent or temporary, and I use permanent. That's what I prefer. There's a reason for that. I that's a long story, but temporary implants, I did a lot of them, and the problem is if they're to be done properly, you really should have 5 or 6 sessions, and that's just miserable because then you're being told I got to have these needles put in me, you know, 5 or 6 days. The way I used, or 5 or 6 times. What I used to do was actually admit a patient to the hospital and then keep him at the hospital and then do the treatments twice a day. But I tell you, by the 5th or 6th time, the person like, get these needles out of me. You know, it was driving them crazy. But there's also some biologic reasons why I don't like it. Understand that radiation of any external variety, protons, neutrons, photons, is high energy, high dose radiation. And one of the things that we know is that if you deliver high dose radiation to this area, okay, and that's what it has been subject to for several weeks. Cancers do like to defy what you're doing to them, and they try to mutate to become resistant. So then you do temporary implants. Well, temporary implants are also high dose radiation. So there's no change. Cancers don't like change, okay? And so my theory is permanent is the way to go. It's a one-time deal. They don't interact with anything in your body. They become part of you. They're tissue compatible. They don't interfere with MRIs, pacemakers, anything like that. And you don't have to have it done repeatedly. And also because the cancer is then seeing something completely different, and it just fools the cancer. And so these are the reasons why I like using the combined regimen and use a permanent implant.
Yeah. You just put the seeds in once and then you don't have any more seeds again?
That's right.
That's right.
Exactly. Okay. Well, that'll conclude our meeting. Thank you for coming.
Thank you.